Josas Kupčinskas. We are happy to see you and learn more about microbiome and fecal transplantation.
Does this work?
Just and you have 20 minutes, sorry.
I should use the... Is it working? Oh, okay. Good afternoon. It's always a big pleasure to be here in Latvia, in the University of Latvia. We have a very good long-standing collaboration with Professor Maisezlea, who is unfortunately not here. This topic that I'll presenting you today is somewhat a continuation of what some of you might have heard already this morning from Jan Bornstein from Oxford University on microbiota. You know that this is an extremely hot topic, and we'll try to also present some our experience in Kaunas with this. So we know that microbiome is everywhere, and we are just, I think, at a very early stage of understanding what it actually does to our body. We know that it regulates crucial functions related to immunity, related to cancerogenesis, but this is something which we still need to discover. So I won't go much into the details because you probably heard that in the morning, but our microbiome is much more extensive than we knew before, and even the stomach, which was considered to be sterile, now is known not for only Helicobacter pylori infection, but we have other bugs there. So in the acidic environment we have many other organs, not talking about the large colon where you have hundreds of different species with still unknown functions, I think. We start to develop our microbiome very early in our childhood. So babies are born germ-free, so they're very sterile, but in the very early minutes of their life they already acquire microbiota, and it kind of, I'm trying to find the pointer. Okay, so when you are a teenager, your microbiome tends to become a little bit more stable, and when you are adult, it's kind of in this stable line. It's something what remains for quite many years. But if you have diseases, then the microbiota is altered a lot, and what's also known, when we get older, our microbiome diversity goes down. Whether this is linked to some diseases, we don't know, but what we see from many studies, that microbiome is deregulated in different conditions. The major rule is that if you have a disease, your microbiome goes down, the diversity goes down. Why is this? We don't know. Whether this is a secondary cause or primary cause, we have no idea. But from the twin studies, which included also mice, we know that if you transplant feces from an obese twin to a mice, and if you transplant the feces from the other lean twin to another mice, one develops a adiposity phenotype, the other one doesn't. So this is something which very interesting. So now when we are able to analyze this microbiome, we kind of know how to find those bugs in our gut. Of course, the idea is how we can use this information and try to treat the patients maybe, or prevent some diseases. So this is the whole fuss about the fecal microbiome transplantation started some 5 years ago when this paper in the New England Journal of Medicine came out, where the Dutch group showed that for recurrent Clostridium difficile infection, fecal microbiota transplantation is extremely effective method of treatment. So with repetitive fecal transplant, you get prevention from this disease to recur in up to 95% of cases. So this is something which is a very large proportion of responders. So there are different methods used for FMT, which I'll discuss a little bit later. But the meta-analysis, which summarize all the treatment data for Clostridium difficile infection, really show that the effectiveness of this procedure is around 90%. to prevent recurrent infections, and this is something what's really striking. In our own department, we have similar data which were presented also this morning. To treat, in order to prevent further episodes of C. diff infection, FMT is something what really helps the patients. So for this indication in Clostridium difficile infection, it's very well established. It's in all guidelines of infectologists and all other gastroenterologists and all other related specialties. So everyone now turn their attention to other indications outside C. diff. Since we know that our microbiome is deregulated in many conditions, it's very tempting to evaluate whether this treatment modality could be valid for other diseases. So if we look down here, this is a study coming from US. What they did is they compared the microbiota in kids born in USA, and they compared this microbiota with kids born in Tanzania and Malawi, so less developed countries. So what they clearly see that the microbiota of the newborn babies in USA, it's much less diverse than those who are born in less developed countries. So this idea that extremely good hygiene conditions, which are now present in the West, could be the cause of our modern age disease. This is up here, this is just one slide from our paper, which was some years ago published in GUT from our group, where we tried to compare microbiota from people in Germany, Lithuania and India. So in Lithuania we see that our microbiome is more rich than the German microbiota, but is less rich, less variant than the Indian one. So I don't know what's the situation in Latvia, maybe you have your own data, but this idea that more developed countries have less diversity in their guts is something what is seen in many papers. So if we look now at FMT clinical trials, and if you go to the clinicaltrials.org webpage, there are more than 200 registered trials going on in this field. So most of them focus on ulcerative colitis and Crohn's disease, but there are other indications like irritable bowel syndrome, acute pancreatitis, hepatic encephalopathy, constipation, metabolic syndrome, and many others. So most of them are still recruiting patients, but there are some which have already completed and are already published. So I'll show this data briefly to you today. So of course, most of the people working in gastroenterology, like me, expected that the next treatment target with FMT will be inflammatory bowel disease, because you have inflammation in the colon and you have altered microbiome diversity there. So this is what's known for many years. You also have genetic predisposition for this disease, which is related to the genes which are involved in recognition of bacterial pathogens. You also know from the animal models that if you can, by modulating the microbiome in mice, you can exacerbate or make the inflammation in the colon lower. And again, there are some reports on antibiotic or probiotic effects in treatment of these diseases. So the first trial, which was published a couple years ago on ulcerative colitis patients, they included 37 patients. They performed fecal microbiome transplant at the baseline, and then 3 weeks later, so they divided the whole group into two. One group received a healthy donor FMT, and the other one received their own feces. So in this group, the response rate at week 12 was nearly 41%. So this is one of the largest studies which is present there. The last study, the biggest study, comes now from Australia. So in this study they included the patients who had steroid-resistant ulcerative colitis, so they did not respond well to steroids, and they did FMT for those patients. They found that in FMT arm, the response to was 27% compared to 8% in the placebo group. The regimen in this study group was very, very harsh. So for 8 weeks in a row, nearly every day, we were giving fecal microbiota transplants via NMS. So, and evaluated the response at 8 weeks. So this is really something which as a treatment option in the long run would not be probably acceptable for many of the patients, but the fact that there is some effect on clinical behavior of the disease is very important. The one study which is now already published in metabolic syndrome is very small. It includes only 18 patients, but what they did is for 9 patients with metabolic syndrome, they used the feces from the donor, and for the other one they infused feces of the same person. So from this small study they found that the hyperinsulinemia is better controlled in those 9 patients who received the feces from an other patient. So this is from another donor. So this is something which is again interesting, and there are much bigger studies being done now, so we are waiting for those results. The last study, the last clinical trial which just came out is on the use of fecal microbiota transplantation for treatment of hepatic encephalopathy. You know, this is one of those most severe complications of a cirrhotic patient, and what they did in the study, so they divided the study into 2 arms, and for one group again they gave placebo, and for the other group received FMT. So those 10 patients who received FMT and also the control were followed for median of 50 months, and they tried to assess the recurrence of hepatic encephalopathy episodes in the longer run. So what this study shown, that those patients who received FMT at the evaluation at the day 150 after the fecal transplant, the much higher proportion of patients were hepatic encephalopathy free of episodes from hepatic encephalopathy when compared to the control groups. So this is a very small small study. Just 10 patients in each arms, and although it was published in the major journal Hepatology, it was criticized a lot for various technical issues. But what they showed in this study, that patients who received FMT, their microbiota on day 20 was restored almost back to normal, while those patients who received just placebo, their microbiota remained stable. So absolutely, microbiome is changed by fecal microbiota transplantation in hepatic encephalopathy patients. Whether this could be some sort of treatment modality, it's absolutely still not clear, but the signal for microbiome composition is there. So currently, most of the FMTs in the world are performed through a nasoilunal tube, or through the colonoscope, or through the method through the Anela's help. But the future is really in capsulized formulations, and also in our lab there is a dedicated group of technicians who have already produced capsules for FMT, and we are using it also for Clostridium difficile patients, as well as for some other clinical trials outside C. diff. So the future probably is not those type of capsules. The future is very specific next generation probiotics, which are already being investigated in many clinical trials. But of course, there are many questions which need to be answered. So which are the really patients which could still benefit beyond C. diff? Which donors? We have a recent case in the United States where a patient, after fecal transplant, she gained obesity, and then she came to the law and sued the doctors because they accused her that they transplant obesity to her, and actually the feces were taken from her daughter who was obese. The doctors say that she just stopped on her diarrhea, and this is just a coincidence. She started eating again and gained weight. But absolutely, the FDA now regulates this procedure in the same way as any other drug. There are viruses which can be transmitted through this procedure, so of course we need to screen donors as much as possible based on the local pathogens that we know, but this is something worth looking ahead. There is some data already that, for example, for liver transplant, for kidney transplant, you need to match the donors, so that we do HLA genotyping and etc. So there are data already which shows that we need to choose the right donor, and he has to be fit for the patient to engraft the microbiome. And of course, what to transplant, probably fecal transplantation as such will be stopped in some 10 years when we have new alternatives. This next generation probiotics with very well defined bacterial consortia probably is a very promising option. And of course, what are the long-term outcomes and what is the long-term safety of the current procedures, we don't know, but from our experience, at least in those patients who have refractory C. diff and they don't respond to standard treatment, this is really very fast helping effect, and they are very willing to receive this treatment, and it really helps. Of course, public is very well aware of those things, and we as gastroenterologists every week get inquiries if we could do this fecal transplant for one or other disease. Many patients with irritable bowel syndrome, or all of you see those patients, they ask if they could get those transplants because they read some paper that it could help. So the inquirement from the public is very huge, and if you go on YouTube, there are many videos how to do this at home. Of course, we don't suggest that patients would do this, but really there are many patients with ulcerative colitis who do this at home, and I know at least one patient in Lithuania as well. So we need to do research a bit faster so that we can provide those answers to the patients, but this is what is happening. Yeah. So this is the last slide. Maybe some of you already know, but in September we are going to have a European Microbiota Study Group conference in Kaunas. You are all very well invited to be there, and you'll hear much more about microbiota there. So thank you.
Questions, please.
So I will ask about gut microbiome and brain axis connection, because what I feel here, there could be also relation between the donor emotional condition and behavior, and the patient. So did you observe any change in maybe emotional state and mood, maybe some, I don't know, physical activity increase after the transplantation?
This is an excellent question. Personally, we are not doing research related to the gut-brain axis, but there are many studies where they show that in anxiety in Parkinson patients, the microbiota is altered. There is now one very interesting study published in Nature where they basically show that the diversity of our microbiota tells us what we actually eat. So basically, if you have a certain enterotype of microbiomes, they require more carbohydrates, and they make us eat them. So this is a very interesting concept. And of course, they produce metabolites which go to the blood and circulate and have effects on the brain. But this is still way before clinical application. So,
more questions? I have a question. Is it about replacement or really treatment? I mean, is it about just patients changing their microbe due to disease and treatments and just replacing it, or it has some treatment kind of benefit?
Sorry for my throat once again. This is a very good question. I mean, whether this is a secondary cause due to disease or this is a primary cause, we don't know for sure. So this is at the investigational stage, and I think all those mice models and clinical trials is the only way to get the real answers, because in my view most of these changes are secondary due to disease, they are not pathogenic. But I can tell you one experience from our patient with liver cirrhosis and recurrent C. diff. So we transplanted the feces for C. diff infection. After 2 days his acne from the face was gone, and he had it for 30 years. Okay, so this is, of course, might be coincidence, but I think there is much more in the gut than we know now, so that's for sure.
Thank you very much. We are happy to see you in Riga again.
And now we will invite Medicīnas to tell us about the achievement of guideline-defined treatment budgets in diabetes patients in Latvia.
Good afternoon, my name is Sabina Stribinska, and it's my pleasure today to present our study about factors associated with achievement of guideline-defined treatment targets in Latvian patients with type 1 diabetes. According to these both guidelines, American Diabetes Association and European Association for Study of Diabetes, they are general goals for patients with type 1 diabetes. For HbA1c, there is less than 7%, low density lipoproteins less than 2.6, but if there is cardiovascular diseases, albuminuria, or age over 14, then these goals are more restricted, and these are less than 1.8. For triglycerides, the goal is less than 1.6 millimoles per liter, and for arterial blood pressure, the goal is less than 114 to 19, but if albuminuria is present, then this blood pressure target is less than 113 to 18. So now, also lifestyle management is very important. For those patients, it's very good regular sport activities, and also stop smoking. And our study purpose was to analyze how guideline-defined treatment targets are achieved in Latvian type 1 diabetic patients. And the second objective was association of depression, metabolic syndrome, and physical activity on diabetes control. We use data from a Latvian diabetic nephropathy study cohort. Also, these two mentioned guidelines. In the urine, we measure albumin-creatinine ratio. Glomerular filtration rate we calculate using CKD-EPI formula. And also we use two tests, one for depression, its name is Back Depression Inventory Test, and another Minnesota Leisure Time Physical Activity Questionnaire. And metabolic syndrome was defined if two or more components were, and it was like waste or triglycerides, high density lipoprotein, or hypertensive or use of antihypertensive drugs. And our study results altogether, we analyzed 316 patient samples, of whom 46% was male. The mean age was almost 37 years, and duration of diabetes average 17. HbA1c percent was 8.9%, and the majority of our study population was neuropathy and retinopathy, and nephropathy was present of 1/3. And also smoking, active smokers were almost 30%. The HbA1c goal achieved only 12% of our patient sample, and arterial hypertension was in 46 cases. And what was surprisingly that 26% didn't use any antihypertensive drugs. Low density lipoprotein and triglyceride goals achieved 20% and 17% of our population respectively. And about achievement of treatment guidelines, of treatment guidelines, there was an impact. I don't know how to switch the pointer. Oh, yeah, it works. We found that there is impact between a higher socioeconomic status and achievement of low-density lipoprotein goal. Also, for depression, those patients who had no depression in history, there was better to achieve HbA1c goal and also triglycerides. There was no statistically significant achievement for group for physical activities, although there is a tendency with HbA1c. And for metabolic syndrome, there was a better statistical significance between three measurements, and it is for low density lipoproteins, triglycerides, and also arterial hypertension. And conclusions: only a minority of type 1 diabetes patients from Latvian cohort achieve guideline-defined treatment targets, and also lifestyle factors as depression, socioeconomic status, and metabolic syndrome are associated with results of diabetes treatment. Thank you.
Other questions from the audience? I have a question. What is your explanation about these results?
In Latvia, perhaps it is less of information why people, because people are maybe less informed about these goals, and they don't go to the doctor very often, and they don't do analysis regularly.
Thank you, Sabine. And now we will invite the next speaker, who will be Unda Kalke, and she will also speak about the diabetes, but diabetes in pregnancy.
Good afternoon. Today I would like to introduce you with a research, the impact of weight gain, glycated hemoglobin, and arterial blood pressure on type 1 diabetes in pregnancy. Type 1 diabetes mellitus women experience more weight gain during pregnancy than the average population. In most of the studies, the main problems are related to premature birth, the risk of macrosomia, and also the risk of hypoglycemia of the neonate. It is essential to plan pregnancy and to achieve optimal glycemic target when glycemic hemoglobin is less than 6.5%, and that could reduce the complications during the pregnancy. The objective of the current study was to show how weight gain, glycemic hemoglobin, and also the blood pressure affects the pregnancy and its outcomes during the pregnancy for patients with type 1 diabetes mellitus. A retrospective study was performed and were analyzed overall 32 medical histories with type 1 diabetes women during pregnancy in the time period from 2013 till 2017 of Paul Stradiņš University Hospital. For data processing was used the SPSS program. From the results of the study, a positive correlation was found between the maternal weight before pregnancy and the weight before delivery. Also, out of 32 pregnancies, most frequently, or it is 37.5% of births occurred in the 37th week of pregnancy, and 18.8% of children were born prematurely. Also, out of 32 pregnancies, 18 were planned but 14 were not planned. And in cases of unplanned pregnancy, the average glycated hemoglobin was 8.2%, while glycemic hemoglobin for planned pregnancy was 6.8%. This graphic shows that in case of glycemic hemoglobin less or equal to 7%, before pregnancy, the average weight gain during the pregnancy was 14.6 kilograms. However, in case of glycemic hemoglobin more than 7%, the average weight gain was 19.7 kilograms. Furthermore, of women who had preeclampsia, the average weight gain was 18.4 kilograms. Comparing to women without preeclampsia, the average weight gain was 14.7 kilograms. And in neonates who experienced postnatal hypoglycemia, their mother weight increased by an average of 20.8 kilograms during pregnancy, but in neonates who had no hypoglycemia, their mother weight gain increased by 14.8 kilograms. The conclusions of the study. Increased weight gain during pregnancy in type 1 diabetes mellitus women correlates with an extra weight already before pregnancy and increases more than in common population. Also, in type 1 diabetes pregnancies, approximately 56% of deliveries occurred in the 40 weeks. And the risk of preterm delivery is approximately 19%, and that also is higher than in the common population. The average glycemic hemoglobin is lower in case of planned pregnancy, which means that planning is very important, and because elevated glycemic hemoglobin is associated with pregnancy-associated complications. Glycemic hemoglobin less or equal to 7% before pregnancy is associated with lower weight gain during the pregnancy, while glycemic hemoglobin more than 7% is associated with higher weight gain during the pregnancy and, of course, its related complications. The risk of preeclampsia for type 1 diabetes mellitus women positively correlates with a higher weight gain during the pregnancy, and higher weight gain during the pregnancy strongly correlates with neonatal hypoglycemia. Thank you for your attention.
Questions, please? Then I have a question. How do your data compare with the literature data, and how do you explain, especially related HbA1c and increased weight gain?
Yes, the more increased the weight gain is, the more probably is the, well, I would say, the resistance of the insulin. So the higher is the glycemic hemoglobin. And as literature says, then approximately in common population, the average weight gain is 16 kilograms. And again, it is very important is the weight for the mother before pregnancy is low or high. And for mothers who have high, already overweighted, then this increased weight gain should not be so increased. It's approximately, well, till 10 kilograms, but in my research it was already 20 kilograms. So it's opposite to, I would say, the common population. And also the preterm delivery in the common population in Europe is approximately till 9%, from 5 to 9%. But in my research it's already, as I said, 19%.
Okay, thank you. Then we should be very strict with women.
Yes, and then of course it's very important to plan the pregnancy. Yes, thank you.
So Lautiņa association between age. Oh, no, sorry. Julia.
Yeah, so to continue the diabetes topic, I think Julia Zavoritina will talk about misdiagnosis of type 2 diabetes for patients with latent autoimmune diabetes.
Good afternoon, dear colleagues. My name is Julia. I'm the 6th-year student of Riga Spanish University, and today I will tell you about the misdiagnosis of type 2 diabetes mellitus for patients with latent autoimmune diabetes in adults in Latvia, which is also called LADA. So according to the Immunology of Diabetes Society, LADA is initially non-insulin requiring diabetes, which is diagnosed in people aged between 30 and 50 years old, which are positive for at least one of the 4 autoantibodies. They are islet cell cytoplasmatic autoantibodies, anti-glutamic acid decarboxylase 65, autoantibodies to intracytoplasmatic domain of the tyrosine phosphatase-like protein, as well as insulin autoantibodies. The most frequent of them are ICA and anti-GAD65. So LADA is also sometimes unofficially called type 1.5 diabetes mellitus, which shows us that it is similar both to the first type and to the second type of diabetes. Initially, the control of LADA patients is reached only with diet, but with time, when the disease progresses, the dietary control fails because beta cells are with time destroyed and they need insulin. So in Latvia, diabetes is diagnosed using World Health Organization's clinical criteria, and autoantibodies detection in the serums are not paid by National Health Service. So I think that it may be a reason why LADA is missed and diagnosed as type 2 diabetes mellitus in patients, and they are treated incorrectly with oral hypoglycemic medicaments. So the patients are developing all the complications which are typical for diabetes. According to epidemiological studies, LADA may account for 2 to 12% of all the cases of diabetes. And in previously published study of 125 adult phenotypic type 2 patients screened for autoantibodies, almost 30% patients were positive for at least one autoantibody, which means that basically they had LADA. The aim of our study was to find out if there are many misdiagnosed as having type 2 diabetes LADA patients in Latvia, and if it is effective to recommend autoantibody screening for better LADA diagnostics in Latvia. The inclusion criteria were the diagnosis of type 2 diabetes mellitus, age between 20 and 60 years old, and body mass index lower than 30 kilos per quadric meter. Patients were selected using the genome database of Latvian population, and serum test for GAD65 autoantibodies using indirect immunofluorescence method was performed. So the results. From 2,439 patients with type 2 diabetes mellitus, only 128 individuals satisfied all the inclusion criteria, and only one patient, which is less than 1%, had positive anti-GAD65 result. According to the current research and anti-GAD65 test, the problem with LADA diagnostics is not crucial in Latvia. However, it would be nice to widen the study population because we used only this biobank And actually, there are much more patients with type 2 diabetes in Latvia, as well as we had limited serum quantity because it was frozen in the database and it was many times used for different analyses. And also we had limited financing, so it would be nice to repeat these tests using fresh serum samples to check all the false negative results if they are there, and to check this positive one result. Further research also is important for evaluation of presence of other autoantibodies and for more accurate findings. I would like to express my acknowledgements to the Latvian Biomedical Research and Studies Center for support and financing, as well as to Genome Database of Latvian Population for kindly provided serum samples. Thank you for your attention, and questions are welcome.
Other questions from other diabetologists in the room, or internists, or infectionists? No, then I will ask. Maybe clinically, it's a debatable question about your hypothesis, because usually when a patient develops diabetes, and we mainly, at least in Latvia and in Europe, we also determine C-peptide to see on the endogenous insulin production. So if the C-peptide is low, then of course we do not give oral antidiabetic drugs. So maybe on the background there was a little bit this weak point.
Yeah, I understand your thought, but unfortunately I asked few general practitioners, and they answered that they don't know about LADA. They were heard about it for the first time. And I told them that it's a real problem, and there are studies which show us that it is a problem, and that's why they don't check this C-peptide in all the patients who are likely to be LADA patients. So I think that maybe the biggest problem is information, that we should informate all the doctors, not only endocrinologists, about this type of diabetes, and to popularize this.
The diabetes is poorly treated, I agree, yes.
Yeah.
Okay, thank you very much.
Thank you.
Okay, now the next speaker is Elina Kalaupiņa. Association between age of the transplant recipients and renal transplant function after 3 years of follow-up.
Good afternoon, highly honored chairpersons, ladies and gentlemen. According to European Renal Registry data, the amount of patients over 65 years is increasing and constitutes 22% of the prevalent renal replacement therapy population. Renal transplantation is the best option in patients of advanced age, but specialists are still reluctant to register elderly patients for renal transplantation. The aim of our study was to evaluate outcomes in older people after renal transplantation in 3-year follow-up. We analyzed patients who received renal transplant between year 2008 and year 2011. In further analysis, recipients were divided into 2 groups, younger and elderly group. Function of renal transplant was measured by the serum creatinine level. This function of renal transplant was defined as a serum creatinine level greater than 0.2 millimoles per liter. We used binary logistic regression model adjusted for personal covariates, diagnosis, and comorbidities. And now about the results. Here you can see the characteristics of renal transplant recipients. 90% of patients were in younger group, only 10% in elderly group. But both groups were comparable by the gender, according to gender, and the mean age of donor. There were only living related donors in young recipient group. About the primary diagnosis. In younger group, majority of patients, the primary diagnosis were chronic glomerulonephritis, 41%, and cystic kidney disease, 12%. In elderly group, the primary diagnosis in most cases were hypertensive nephropathy and chronic interstitial nephritis. As for comorbidities, in younger group, 60% patients had hypertension, 12% had cardiopulmonary diseases, and 11% infection. In elderly group, were noted that 47% have hypertension and 26% have cardiopulmonary disease. As for complications, the main complication in both groups were infection and renal transplant rejection. In younger group, constitute 29% and 47% respectively, and in the elderly group, 35% and 23%. Here you can see the serum creatinine levels in 3 years. This graph shows the mean serum creatinine level in both groups. The green curve shows younger recipient mean serum creatinine level, and the blue one shows the elderly. As you can see, the serum creatinine levels during 3-year follow-up were not significantly different comparing in both groups. Now about the renal transplant function at 3-year follow-up. The light blue color is for normal function, and dark blue is for dysfunction. As you can see, in 3-year follow-up ratio between dysfunction and normally functioning renal transplant were similar in both groups. In our logistic regression analysis analyzing the factors that can affect renal transplant function, we found that only female gender was affecting renal transplant function. And here you can see the function divided by the gender. And after 3-year follow-up, female gender was the protective factor for renal transplant function. As conclusions, our study demonstrates significantly smaller amount of elderly recipients in renal transplant population. Patient's age did not affect the dysfunction of renal transplant at 3-year follow-up. Female gender was protecting factor for renal transplant function. So renal transplantation should be encouraged for the appropriate senior patients. Thank you for your attention.
Questions, please?
About I missed maybe you talked about the gender, that female gender was protective. Was it also in postmenopausal it was protective? Only generally? Did you divide when you looked on the gender as protection factor? Was it protective before menopause and after?
No, it was just like female gender.
In diabetic nephropathy, postmenopausal women lose this protection.
Yeah, so this was only a small part of my study, and I'm now analyzing other factors that can affect the renal transplant function in general.
Very interesting data. And now we will invite Maris Gokovskis, who will introduce the pulmonology in this session, and he will talk about an open label solo pilot study of ultra-long-acting beta-2 agonist and compared with short-acting agonist. I think, Maris, please tell us correctly.
Thank you for introduction. Good evening, dear colleagues, dear chairmen. Yes, we are moving from excellent speeches about diabetes to respiratory tract. I think the next presentation will be about the same, or at least close to it. And I will present our data about open label crossover pilot study of 2 bronchodilators, aldosterone and salbutamol, in patients with obstructive lung disease. This is our conflict of interest. I think I should give some explanations first. why we did this work. Actually, we have two main classes of bronchodilators: beta-2 agonists, adrenergics, and anticholinergics. So today we will speak about this class. We can classify them into the fast-acting and slow-acting ones, and short, long, and actually we can divide or find the third group, ultra-long-acting beta-2 agonists. And in this case, salbutamol is typical fast-acting, short-acting bronchodilator. And the question is, what is the place of olodaterol, one of the newest beta-2 agonists? Everybody knows that this is ultra-long-acting, 24 hours. But the question is, maybe this is the first fast-acting, ultra-long-acting beta-2 agonist. We are using beta-2 agonists actually in everyday practice in such diseases like asthma and chronic obstructive pulmonary disease. And, for COPD, for example, bronchodilators and beta-2 agonists are the cornerstone of the treatment. The first choice, monotherapy or combined therapy in patients with COPD. In asthma case, we are using them together with inhaled corticosteroids, LABA, long-acting beta-2 agonists, and LAMA, long-acting anticholinergics. In step 3 to 5 of global initiative of asthma guidelines, treatment scheme. And another one case, why fast-acting is important, because one of long-acting beta-2 agonists, old one, developed in 1970s, actually has, like formoterol, has fast and long-acting way. And we can add it as additional treatment instead of salbutamol. We use salbutamol per knee. In this case, we can use ICS and formoterol combination per knee in such patients. Therefore, the goals of our pilot study were to compare bronchodilation effect of olodaterol and salbutamol on main lung function measurements, like forced expiratory volume in the first second, or FEV1, effective lung resistance, forced expiratory volume in the first second, and forced vital capacity ratio, and residual volume within the first 30 minutes after inhalation of one or the second bronchodilator. The study was performed in open label crossover manner in patients with diagnosis of asthma according JINA guideline criteria and reversibility, which was observed in the previous year before study, and COPD and asthma COPD overlap. Serial lung function measurements were performed, as I mentioned, FEV1, effective lung resistance, FEV1 FVC ratio, and residual volume according to European Society and American Thoracic Society guidelines, using whole body plethysmography before inhalation and 5, 10, 20, and 30 minutes after inhalation of 5 micrograms of olodaterol, using Respimat inhaler device and 200 micrograms of salbutamol, pressured metered dose inhaler through volumetric spacer. And statistical analysis was done by program Statistica using repeated measure ANOVA method. 10 patients were included, 6 with asthma, 3 asthma and COPD overlap, and 1 patient with COPD. And there are results of FEV1. We observed statistically significant, small but statistically significant improvement in both treatment groups. We can see improvement with salbutamol was a little bit faster. 5 minutes after inhalation, we get statistically significant improvement after inhalation. Olodaterol gave significant improvement a little bit later, 10 minutes after inhalation. but there was no difference between both treatment groups. The next effective resistance, here we can see decrease, statistically significant decrease in both treatment groups, and here we can get a little bit faster substantial results on olodaterol, 5 minutes and later, and salbutamol gives statistically significant decrease 10 minutes and later after inhalation. The same FEV1 FVC ratio, but here olodaterol gave significant improvement after 10 minutes, salbutamol only after 30 minutes after inhalation. Again, no difference between treatment groups. And finally, residual volume, no statistically significant effect in both groups. Finally, conclusions that this lack of significant difference of lung function parameters at any time point of these serial lung function measurements may demonstrate fast bronchodilatory action of olodaterol. And these results of our pilot study, I think, of course, should be confirmed in the larger clinical trial. And these are acknowledgements of our group. Thank you for your attention.
Questions? Yes, please.
Thank you, very interesting. A question maybe a bit on the side, but with any of these asthma medicine, do they have any effects for people without asthma? I mean, giving increased lung performance or breathing performance? I'm asking this out of curiosity because, especially now during the debates, there's a lot of question concerning the debate concerning the use of asthma medicine as a sort of performance-enhancing drug. But some say that it has no effect on people without asthma, and the asthma medicine only works for people actually with asthma. I don't know if you can comment on.
Actually, if we look at patients or healthy people who get this inhalation, there is no increase of lung function. Maybe another question is how, of course, they improve this performance. I remember funny thing that some 2 weeks ago before Olympic Games, from trolls came information on the internet that Norway team is taking 6,000 doses of salbutamol.
Yes.
I think in large doses it could improve some physical performance because this is adrenomimetic drug. But of course the another question is that of such long distance skiers or skaters, they develop some kind of specific form of asthma, which in most of them stop after they stop their sports activities. It's true.
Okay. Thank you very much. So the next speaker is Klaus Swob, and we will hear about the new Riga agreement of the International Consensus Conference on Nasal Airway Function Tests and its consequences.
Dear Presidium, dear friends, ladies and gentlemen, or however, I will not follow my abstract because it may be boring for you and you are not ENT doctors, especially not involved in theoretical rhinology, but I want to tell you that sometimes are happening incredible things, even if you get the right moment. And that was already the kairos as described by Greece, by the word Greece. In 1984, there have been some people selected from the European Rhinologic Society, and among one he was looking a little bit like Lenin. He is now standing here again. And these guys made a standard for rhinologic function tests. Maybe some of you know rhinomanometry, which is nothing else than measuring pressure and flow through the nose and setting it together in a useful relation. Now at this time, not all CSE units have been introduced, and it was really necessary because it was the beginning of the introduction of computers in measurement methods. It was really interesting and important to get some common ideas how to make graphics and what to calculate. Unfortunately, later on, this so-called ISCOANA, this International Standard Committee, got a big political meaning. But what is always the follow-up of a big political meaning is that there's no any more scientific outcome. A lot of talk about clear sky. So, when I came in this country as a guest professor 15 years ago, then we started to work about the problem. And the first what we did was to make a critical evaluation of existing methods and a summary of the physical and mathematical basement of nasal breathing, which was not so easy. And then people contributed to this special supplement, which was even difficult to publish because nobody wanted to know anything about physics in practical medicine. But it is necessary. So the next one, what we did is that we did not believe anymore these simple things and curves which not have been existing. We followed simply the basic ideas of electroengineering and said, okay, if we are measuring a wave, then we can divide it we can measure the integral under the curve, and then we are doing nothing as if the electrician is coming in our room and looking why our lamps are so dark or not. So that is nothing but the effective and the peak flow resistance. This is a little bit different from the peak flow which is used in pneumology because it is measured during normal breathing. So having done that, then it was again necessary to bring two guys from Saxonia, which is my homeland, back into the history and to bring back the basics of psychophysics into the medicine, and feeling how obstructive is your nose is basically nothing as it is following logarithmic steps like hearing, you know, the dB scale, like smelling. You can smell something very easy, maybe any person and so on, but not if it is in the car stove. And something like that. So, if I'm blinded and anybody is pouring in this empty pot water, then of course I feel it and drink it. If I have in both arms a barrel, after making a cup, that is 7 liters normally, and you add this amount, you are not able to feel it. It's impossible. You do not see the sun during the stars during sunshine. same thing. And that is an old wisdom from Weber and Fechner at the end of the 19th century. But it was never introduced in rhinology. So a lot of correlations between parameters, subjective feeling, endless discussion have been started, but never introducing the logarithmic scale. And that is what we also did. And then came my wonderful students and diploma students from Riga. And we collected by a technique which I inaugurated 10 years ago, 36,563 clinical measurements in 6 big hospitals which are following my technique for the unilateral measurements, and then 2 others followed it with the measurement of the total resistance in 10,033 cases. Doing that, it ended all of a sudden the discussion about meta-analysis. He says 25 cases, he 111, and so on. And meta-analysis are analysis of things which have been normally done 10 years before. So in our modern life, they are almost useless. Sorry about that. So, and then from that we could derive a clinical classification of nasal obstruction in Caucasians. As everybody knows, Chinese guys and Japanese guys have smaller noses, and the black ones have wider noses. And so you see, after logarithmic transformation, a nearly perfect normal distribution, and you can divide it in 5 groups, and then so you say, yes, this is a very good, and this is a lousy nose. So, and this is absolutely applicable clinically, and so if you do surgery and you improve it from a moderate nose to a 1 class higher, then your patient will be probably grateful. Then again, the biennial discussion about these things completely useless started, and Kasper Pexis and me, we decided we ask our rector, and we call an international and interdisciplinary consensus conference with people which have written really good papers, and all of a sudden 20 people, 16 of them international experts, came to the aula in our main building, and that was on November 2016. And 2 weeks ago, after enormous contradictory remarks which have been completely useless, this new agreement of the International Riga Consensus Conference on Nasal Function Tests was published in open access in rhinology, and everybody can read it now. And that means Riga is now the capital of the nasal airway function tests. So, I'm happy. And but the most important is, of course, that was totally unexpected, but what was still more unexpected, nobody went go home. And the discussions ended the next morning anywhere, mostly in the Elephant Hospital, not hospital, hotel. And we found that meanwhile 3 groups have been everybody stayed together, 16 people. And among them, a research company in Graz, in Austria, the Rheinisch-Westfälische Technische Hochschule in Aachen. This is the same technical high school which invented before World War II the Messerschmitt planes. They are really insiders. And also the Nuclear Research Center in Jülich, and 2 SMEs. And what is now coming is that we are looking again the meaning of an old guy named Bernoulli, who made it possible. He was doing the interpretation of flying, of sailing, and so on. And what we are doing now is measuring the elastic structures of the nose. And that will be, hopefully, the hit of diploma works this year. So, the other thing is, I'm stopped immediately. What we want to set up here, and that is the meaning because I'm here. We want set up also in Latvia and Estonia and Lithuania together here in Riga, a nasal service center where we can merge also computational fluid dynamics and these physical things. And now I have to apologize for being too long, and I want to thank all my wonderful diploma students. Bye-bye, thank you.
We don't have time for questions, unfortunately. It's 11 minutes. So I would like to introduce next speaker is Håkon Overland, and we'll talk about invasive disease caused by strep pneumonia caused by University.
Okay, good afternoon everyone, colleagues, ladies and gentlemen, chairman. My name is Håkon Overland from Norway. I'm a 6th-year medical student here in University of Latvia. And today I'm going to present to you part of my diploma work, which is named as invasive disease caused by Streptococcus pneumonia in the Paul Stradich Clinical University Hospital. So, Streptococcus pneumonia, this is a gram-positive bacteria that is also alpha hemolytic organism, and as you can see from this picture here, it usually goes in the shape of like a diplococci, which sometimes it goes by this name as well. This is the most common cause of community-acquired pneumonia, but in some cases it might also cause more invasive disease, such as sepsis or meningitis. However, the resistance rate towards Streptococcus pneumonia in healthy individuals is very high, because as a fact, this bacteria is part of the normal flora residing in the oropharynx in approximately 5 to 50% of all the population. So in order for the disease to develop, there need to be certain risk factors present, such as chronic diseases, disease that is lowering the immunity, such as HIV, for instance. Also splenectomy. These are some examples of risk factors. So, against this disease, or this bacteria, we also have a very effective vaccine. It's called so-called pneumococcal conjugate vaccine, and it is in 2 variants. It's in a 10-valent and 13-valent vaccine. And how it works is that Streptococcus pneumonia has a very particular kind of capsule, which is made out of like 85 different like antigenically different types, which is like the main importance in accordance to its virulence factor. And these vaccines are targeted against the most common serotypes of the bacteria. And so in the 10 and 13 valent vaccines, these are covering respectively 10 and 13 out of these most common serotypes that are causing more than 80% of the diseases by this bacteria. And this conjugated means that there's like the bacterial capsule that is linked to a variant of diphtheria toxin. And like I said, it's directed against the most common serotypes. So the purpose of our study here was to characterize the invasive pneumococcal disease in Paul Stratnish Clinical University Hospital. As you can see from this figure, pneumococcal disease is subdivided into invasive and non-invasive disease. So we're going to focus mainly on meningitis and bacteremia down here. What we were using was the hospital microbiology database and medical records, and we used this to extract information about antibiotic resistance and serotyping. In our study, it was included 26 patients. That was taken from the year 2016 and also until November 2017. The mean age of the women that was included was 66.4 years and 62.5 years of the men. Out of these 26, 22 patients had sepsis and 4 patients had meningitis. In this graph, you can see the prevalence of resistance in the invasive isolates that were tested in our study. And as you can see, penicillin had a resistance rate of approximately 5%, trimethoprim sulfamethoxazole had 21%, clindamycin 10%, erythromycin 5%, and tetracycline 10%. But against Streptococcus pneumonia, the number one antibiotic of choice, this is penicillin. As we look at serotyping, you can see here that there was a total of 18 patients out of the 26 that had serotyping available for us to analyze. And out of these 18 patients, you can see that 8 of them had serotypes that were covered by the vaccines. And if we further subdivide them, you can see that 6 of these 8 patients, they had serotypes that were covered by both the 10 and 13 valent vaccine, and 2 patients had serotypes that were covered only by the 13 valent vaccine, which is the latest one. We also found that there were 10 patients out of these 18 that had serotypes that weren't covered by the vaccine at all, which makes it so that even though we would have given these patients the vaccine, they still would have caught the disease, which is quite interesting. The most common serotype that was covered by the vaccine was the 19A, as you can see here, with 2 cases, and the most common serotypes that weren't covered by the vaccines were 9N with 2 cases and 11A also with 2 cases. So the question is, like, why is it so? Why is this? Why is it that we see these serotypes that aren't covered by the vaccines? And we have the reason to believe that this is in connection with the introduction of the pneumococcal vaccine in the children vaccination program here in Latvia that was initiated in 2010. And there could be so that after, in this period of time up till now, that there has been a selection of non-vaccine serotypes that could have developed from 2010 up till now, November 2017. This means that we should further, very carefully monitor serotypes of further invasive pneumococcal diseases in order to see where the trends are going. And we should also include children in further studies, because as of now we have only adults that we were analyzing. So what we can conclude with is that the antibiotic resistance are very low, which is very good. And as we could see from the results, penicillin resistance was only 5%, which tells us that penicillin still remains as a very safe option for treatment. Also, only 44.5% of our patients had pneumococcal serotypes that were covered by the vaccine, meaning that there are still 55.5% of patients that would have caught the disease, even though they would have had the vaccine from before. Thank you for your attention.
Questions? Question. I cannot ask questions. I was a co-author. Okay.
I have just one remark. If you say in your conclusion that penicillins is a very good option for treatment of this group of patients, that is of course according to literature data. But if you say in your study, then you should show also us results. Yeah, did penicillin really helped to these patients? What were included?
This is something that, because this is part of my diploma work that I'm presenting here, and we haven't finished it all, and we still have certain factors yet to analyze, and this is going to be one of the parts that we haven't
checked. You will
checked.
go on with this study
and
show also these clinical results, recovery or more complications.
Yeah, we also want to look into like these patients, like from which wards are they, like how many survived, how many died, how many had certain complications, and so on. Yeah. Thank you.
It's a deadly disease, invasive pneumococcal disease with a high mortality. So just want to explain that it's not always treatable. Okay, thank you.
Thank you very much. Now we will proceed to the next speaker, Olga Barbara-Kramer, the immunologic response to hepatitis B vaccination in peritoneal dialysis patients.
So, good afternoon, ladies and gentlemen. I will present you my study about the immunologic response to hepatitis B vaccine in peritoneal dialysis patients. So, why this is an important topic. So, hepatitis B infection is one of the leading infectious diseases, and 2 billion people are having serological evidence of present or past infection of hepatitis B. Especially the dialysis population is having increased risk for achieving and acquiring hepatitis B. The reasons are, for example, invasive manipulations, the dialysis machines themselves, if you handle infected material, blood transfusions, and also the immunodeficiency caused by uremia. So prevention, of course, are usual infection control measurements, but also what is important is the vaccination. So we looked at the vaccination, especially in peritoneal dialysis patients, how they responded to the vaccine, and which factors may influence the vaccination. So, for the patients and methods, this was a retrospective study which was done in Post-Residenz Clinical University Hospital at the Nephrology Center. I collected the data from patients who were included and in the peritoneal dialysis program from 2014 to 16. There were several exclusion criteria, especially if the patient already showed serological evidence of past or present infection, or if the patient did not receive a vaccination when he was enrolled to the PD program. Some did not finish the vaccination schedule, so we could also not include them, and in some there was no anti-HBs titers available after the vaccination. The vaccination was according to the guidelines of the CDC. So 40 microgram of recombinant vaccine was injected into the deltoid muscle at a 4-dose schedule at 0, 1, 2, and 6 months. So what we looked at, there were some demographic data, there were lab data we looked at, which may influence the immune response. This was age, gender, diabetes mellitus, hepatitis C infection, the body mass index, as well as the time of the vaccination. If the patient already started dialysis, or if the vaccination was after the patient started dialysis regarding uremia, and the time on dialysis in month. From the lab data, we looked at the serum creatinine, urea, CRP, ferritin, albumin, and parathyroid hormone. And here I looked at the data at the first point of the vaccination, so at 0, then at 1 to 2 if there was data available, and at the last point of the vaccination. Then the titers were assessed as well to see how many patients are responding to the vaccine. So this was at 1 to 2 months after the vaccination and after 6 months to see how the titers are developing. Just for definition purposes, non-response was defined as titers of anti-HBs less than 10 international units per liters, and above this was defined as seroconversion. Statistics were done with SPSS, and significance level of 5% was statistically significant. So the flow chart of the study. So initially we analyzed 90 patients, but at the end just 42 patients could be included. Here you see the exclusion criteria again. I just want to mention that a quite high percentage of numbers of patients showed serological evidence of already present or past infection, which is 23.3% of prevalence, which is very high. So then we included 42 patients, which were balanced, 50-50% male and female. And then we looked at the vaccination after 1 to 2 months. So we could see that 71.4% of patients really responded to the vaccine. If you can compare this to the general healthy population, usually a response of 90 and more percent is expected. Then after 6 months of the vaccination, we tried to evaluate again how the titers develop. Unfortunately, again, 20 patients had to be excluded because we did not get follow-up titers. At the end, we could then see that part of the initial responders already lost titers. So 13.6% of patients lost the titers already after 6 months. And in 82%, the anti-HBs titers dropped quite heavily. Then what was also quite interesting finding, I followed up the patient when I did the data collection in September to November 2017. We looked also at the patient outcome, what with the patient happened after this time. And we could see that the patient went to transplantation, to peritoneal dialysis, stayed on peritoneal dialysis, went to hemodialysis, or some of them died. So you could see that when you then look at the seroconversion rate, that the patients who got transplanted after the vaccination had much higher seroconversion rates than the patient unfortunately died in the follow-up. So 0% of the patients who died really responded to the vaccine. So then about the factors which are influencing the vaccination, I will just show you the ones which were statistically significant. On the one hand, we then looked at the responder and the non-responder group, and then we could see statistically significant changes in age. So the non-responders, you can see, were older than the responders. So this was one finding we could see. Then also the C-reactive protein here on the left side at the first point of the vaccination, then at the last point of the vaccination, you can see that the inflammatory markers were much higher in the patients who did not respond to the vaccine than others. And we also could see the patients here at the time point of the first shot of vaccine, in between at the last point of the vaccine, that non-responders had much lower levels of albumin than the responders, that there is some malnutrition. So in the conclusion, we can say that the seroconversion rate is lower than in the general population in peritoneal dialysis patients, that after 6 months you can already see the patients either lose their anti-HBs titers, or that there is some significant drop in the titers, that age and CRP are negatively associated with the response and albumin positively, and that the other factors we could not find any association in between. Thank you for your attention.
Questions? I have a question.
Yes.
Do you think that losing titers would mean that the patients are not protected?
No, that does not mean that patients are not protected, because there are still memory cells present which can, in case of some infection, produce again antibodies. But still, I would say the patient should be monitored after 6 months to see if they really respond, and also to identify the non-responses and do additional vaccination program.
Thank you.
Thank you.
So we have a last speaker. Very good. Victoria Pogodina will speak about complicated urinary tract infection and acute pyelonephritis, comparison between fertile and postmenopausal women.
So, good afternoon, ladies and gentlemen. My name is Victoria Pogodina, and today I will be presenting my scientific topic, complicated urinary tract infection and acute pyelonephritis, comparison between fertile and postmenopausal women. Urinary tract infection is the most bacterial infection in young and elderly women. A complicated urinary tract infection is a urinary infection occurring in patients with structural and functional abnormalities of genitourinary tract. To these days, there are not many studies comparing complicated urinary tract infection and acute pyelonephritis in postmenopausal and fertile age women in Latvia. Purpose of the study was to compare the difference in frequency and etiology of complicated urinary tract infection and acute pyelonephritis in postmenopausal and fertile age women in Paul-Stratton Clinical University Hospital. In the retrospective study were included 57 women, 30 of them were in fertile age women and 27 were in postmenopausal age. In the study, patients' medical histories were analyzed in time period between 1st March 2016 and 3rd December 2017. All these patients were stated in Paul-Stratton Clinical University Hospital, Department of Urology, due to diagnosis complicated urinary tract infection or acute pyelonephritis. Every patient was selected only if the microbiological urine sample was taken before antibacterial therapy was initiated. The comparison of different infection localization in fertile and postmenopausal women can be seen in this graph. It is clearly seen that the prevalence of complicated urinary tract infection is greater. It was greater in postmenopausal age women. It was found in 48%. The opposite situation you can see with acute pyelonephritis, where in 80% the prevalence was found in women in fertile age. Urosepsis were found in 22% of fertile in postmenopausal age women and in 20% of fertile age women. Without any surprise, it can be seen that the most commonly isolated bacterium was Escherichia coli, which was found in 70.2% of all specimens. Other less frequently isolated bacterium was Enterococcus faecalis, Streptococcus agalactiae, Klebsiella pneumoniae, and others bacteria. Please take a look at this graph. This graph reveals that the prevalence of single agent and multiple agent infections in both groups is similar. The multiple infection in 22.3% was found in postmenopausal women and in 30% in fertile age women. The comparison of isolated pathogens between fertile age and postmenopausal women can be seen in this graph. As I have said before, the Escherichia coli was a commonly isolated microorganism. It was found in 80% in fertile age women and a bit smaller in postmenopausal age, in 59.3%. Klebsiella pneumonia and Streptococcus agalactiae were considerably more frequently seen in postmenopausal age women, while completely the opposite picture can be seen in Enterococcus fecalis and Staphylococcus hominis. The conclusions were that the prevalence rate of complicated urinary tract infection and in fertile women was 1 to 4, while in postmenopausal women ratio was 1 to 1.1. No statistical significance was found in prevalence of sepsis and multiple causal bacterium in these two groups. Escherichia coli was most commonly isolated bacterium in 70.2%, which statistically insignificant difference between fertile and menopausal women. A greater number of patients are needed to evaluate whether there may be a significant difference. Thank you for your attention.
Questions? I have a question. If you look at the resistance levels,
it's my purpose for the next conference. I would like to analyze the difference of antimicrobial resistant, and I would like to compare it in women and men, and also in women if the resistance before fertile and postmenopausal. Yes, it will be for the conference of urology.
thank you.
Okay, thank you.
So, the main aim for us was to finish in time. That was achieved by really impressive 25 minutes gain. That was unexpected, but it's okay. I mean, I'm very glad to see you all here, and I think the presentations, in comparison with the previous year presentations, we are going upwards. Clearly, we are going upwards. We get better presentations. We have some competition for abstracts, so not every presentation gets the oral presentation. So I'm really looking forward for students, particular students, to submit more abstracts, present their work, because this is a good stage to start with. Do you have any comments?
Yeah, I agree, and I really enjoyed this session, and all speakers were excellent. Thank you very much. I think you spent a lot of time rehearsing, and also the scientific value. For example, I already have some people to connect with from these sessions for the future collaboration. So thank you very much. And do we close the session? Yes.
Thank you.
Have a nice weekend.
Yes. Right. Good to see you.